resume the scientific sessions. Moving to the third free paper session. May I invite the moderators for this session, Dr. Saumita Bagchi, Dr. Vinod Kumar, and Dr. Jitin S. Kumar. For the first free paper, may I invite Dr. Mahdi Shadnosh to talk on report of the Iranian system of organ donation and transplantation. Over to you, moderators.
Good afternoon, everyone. It's my pleasure I can have a report of trends in organ donation and transplantation over the past 17 years in Iran. It's necessary that I appreciate all of my colleagues in all the Iran, in which the branches that they are trying to have a very good decision. And just a moment, please. Iran is a Middle Eastern country which has more than 82 million population. We have 31 provinces in Iran, which in each provinces at least we have one medical university. The area of Iran has more than 636,000 square miles. It's a Muslim country. And in 2019, we had something about 16,000 car accidents in the roads of Iran. And our estimation is that something about 4,500 to 6,000 brain deaths in 2019. In all of our universities and the trauma centers which are belong to these universities, we have a network which has in some section, we call it RC, Recognition Centers, or OPU, which one is the Organ Productive Units. In which of these sections they have responsibility of some works that they are doing. When some brain deaths are recognized in RC, they transport this is to the OPU, and all of these works go to something about 55 national organ donation and transplantation units that they do the organ transplanting in these centers. Here you can briefly see the history of organ donation and transplantation in Iran, which have is doing since 1935 in Iran up to now. And all the time it has some good progress that you can see in this table. By this table, you can see during these 17 years, PMP in Iran, which is going up year by year, is rising very good. And in 2019, we had some PMP, about 14 that you can see it. Separately by each provinces, you can see here the number of donation in each year between 2013 and 2019. According to the IRODOT reports in 2019, you can see Iran was the ranking of 32 in all the world by actual this organ donation, and 25 in the ranking in whole the world by living organ donation. You can see it here. And also, this shows you the kidney transplanting in cadaver donors and in living donors year by year from since 2002 to 2019. And also different organs here, you can see it in this table, you can see all the organs, the kidneys, heart, lungs, pancreas, intestine, and also liver. You can see it in this table. And also the numbers each by each per year, you can see all the numbers of donation in Iran. And also we had some good experiences in Iran, in our works using mass media platform and cultural activities, also early diagnosis of brain death and specific management of brain death cases, establish OPUs and RCs in all of universities in whole the country, training the coordinators in all provinces, several TPM training courses that have been held for the medical staff in Iran to expand the donor pool, one which use the marginal donors for donation, establish an efficient application for organ allocation that allocates organs based on medical ordinary with the patients on the waiting list. Also, we are going to do some programs as increasing the pool of our donors by making donation after circulatory death, and also use of marginal donors due to the increasing age of donors in Iran, reactivating pancreas transplanting centers, and increasing the number of kidney pancreases and liver pancreases transplanting, design a heart and liver registry system because we have some exactly numbers of them, and also some other works that we are going to do. Thank you so much for your attention.
Dr. Mahdi, that was a very good talk. It's a data of spanning over 17 years. It's a large data. My just one question is what is the percentage of living versus deceased kidney donation in your country?
The percentage of?
That was a very good talk. It's a data of spanning over 17 years. It's large data. My just one question is what is the percentage of living versus deceased kidney donation? In your country? The percentage of spanning over 17 years. It's large data. I think there is significant echo issue. I think we'll move on to the next speaker.
Sorry, I can't hear you good. There is some problem in the hearing, sound hearing here. May you text me?
Sir, you can also put forward your question in the text.
There is some problem in the hearing here. Actually, by these 4 years past, we have changed the percentage of living transplanting in kidney. You know, formerly it was something about 60% diseased, and 40% it was from the living. By now, we approached to 70% living and 30% living and 70% visit. And the aim of us is have going to something about 80% from this is the donation and 20% from the living.
I think there is some technical issues with this. Thank you, Dr. Mahdi. May we now proceed with the next free paper. May I invite Dr. Deepak Shankar Ray for his talk on rabbit anti-thymocyte globulin as induction therapy in Indian patients undergoing renal transplantation. Clinical experience from RICE Registry. Dr. Deepak Shankar Ray.
Thank you. Good evening, chairpersons and ladies and gentlemen. Let me share my screen. This is a study, multicentric study, which is a prospective observational study of rabbit ATG as induction therapy in Indian patients undergoing kidney transplantation. So this paper was also presented in ERA EDTA. There is no conflict of interest for the first two authors, me and Professor Gang. And Dr. Mandrekar is an employee of Sanofi, and Sanofi has funded this study. As we know, several studies have demonstrated that induction therapy with rabbit ATG prevents rejections or kidney renal failure due to immunological rejections. Taylor registry showed that RATG induction was associated with low incidence of rejection and post-transplant complications. In India, due to the lack of robust national registry, there is limited real life data which is available for induction immunosuppression. The design of this RISE registry mirrors the real life management. Here, the nephrologists were allowed the way they were treating. It is just captured, the data were captured prospectively over a period of 12 months. The objective was to study and evaluate the safety and the efficacy of induction immunosuppression using RATG in patients undergoing renal transplantation. Okay. National prospective study, 20 leading centers of India were involved. The duration of study was from July 17 to February 2020. The inclusion criteria, anybody above 18 years were, whether they had a fast or repeat transplant, they were included. And there was an intention to use rabbit ATG as induction therapy, which is independent of this registry. So these patients were taken up. Acute rejections and infections over 12 months were the data was collected. Graft survival and renal function at the end of 6 to 12 months were also documented. Adverse events and serious adverse events over 12 months were also recorded. This is a relatively large study. I'm not able to see one side of the slides, but roughly 312 patients were included in the study finally after exclusion criteria. The mean age of the patients were 42.8 years and majority were men. The mean cumulative ATG dose used was 2.6 milligram per kg. There were acute graft rejection in 23 patients. 22 out of 23 were biopsy proven. One was by other methods. And if we see the graph, that most of the rejections had happened within a month's time, and after 1 month, it has been more or less a flat curve. The rejection-free survival was 93.3% at 6 months and 92.3% at 12 months. Mean time to graft rejection was 1.66 months, and the rejections mostly were cellular. Out of 23, 17 were cellular rejections, 3 were mixed rejections, and 2 were antibody-mediated rejections. The GFR at 6 months, the mean GFR was 64.59, and at 1 year it was 64.93. We encountered 54 infections, mostly bacterial, 37 were bacterial, and 8 were viral, 8 fungal, and other 5. And most of the bacterial infection was due to urinary tract infection, 22 out of 37, followed by other infections like pulmonary, etc. And there were sepsis also in 2 patients. The adverse event total was 154, which includes NODA, anemias, thrombocytopenia, etc. 56 patients had serious adverse events, which is around 18% of total population. We had 7 deaths, 2 due to cardiac problem, 3 due to sepsis, and 2 undetermined. So the summary and conclusion is induction therapy with rabbit ATG showed a rejection-free graft survival at the rate of 92.3% at 1 year. Low incidence of acute graft rejection and infection were found. The safety profile was as expected as in the available literature. Overall, rabbit ATG is an effective, well-tolerated induction therapy in patients undergoing renal transplantation. These are the centers from all corners of India which were involved in the study, and the principal investigators' name have been mentioned. We are thankful to them. We are also thankful to our patients, their families, caregivers, and we are thankful to Anita Gauri for editorial support. Thank you very much.
The talk is now open for discussion. Any questions?
Thank you, Dr. Deepak, for the excellent talk. I think we have some audio issues. Sir, only just a question to you. Was there any higher incidence of cytomegalovirus, BKV infection, or PTLD in patients who have received ATG injection?
There are 2 CMV infections. I believe the rate was low because there was no, CMV kind of studies regularly unless the patient is symptomatic. These 2 must be CMV disease. There was 1 BK virus reported, and no malignancies, no lymphomas. But this is a 1-year study.
Thank you, sir. We will move on to the next talk. I think a few other questions has been posted in the chat box. Sir, you can reply on them. Dr. Soumita has posted a question in the chat box. We'll move on to the next talk. Thank you, sir.
Thank you, sir. Dr. Deepak. We shall move on to the next talk. May I invite Dr. Emre Karakaya to talk on Baskin University long-term outcomes of liver transplant living donors. Dr. Emre.
Dear Chairman and dear colleagues, today I want to present you about our study, Başkent University long-term outcomes of liver transplant living donors. The growing discrepancy between the number of patients listed for liver transplant and the lack of deceased donor organs had led living donor liver transplant to become a life-saving surgical innovation. On the other hand, complications that may occur during or after surgery can have devastating consequences for the donor. For this reason, exhaustive medical and psychological evaluations and a precise anatomical study of the liver should be performed to guarantee the safety of the donor and to provide good results for the recipients. The aim of the study was to evaluate the long-term results of living donors selected according to our criteria. Since 1988, we performed 693 liver transplants, and of the 481 of these transplants were living donor liver transplant. And of these recipients, 366 were adult recipients, and 327 were pediatric recipients. All of the donors were called by phone and invited to the hospital for physical examination, laboratory, and imaging tests. Donors who could not be reached were excluded from this study. Donors who could not come to our transplant center were asked questions about their demographic information, any disease developed, any surgery except donor hepatectomy, regular medication, and their quality of life after hepatectomy. As a result, we reached 129 donors by phone. Laboratory and imaging tests performed on our center. 123 donors were female and 92 were male. The mean age of donor was 45 years. The mean weight of donor was 76.5 kilograms. All donors were related, and the donor's mean follow-up period was approximately 11 years. When we evaluated the laboratory test, we saw that the liver function test, albumin values, and complete blood count parameters, all of donors were in the normal range. Mean albumin value was approximately 5 milligram per deciliter. Mean ACT value was approximately 17 units per liter, and ALT value was approximately 20. Mean total bilirubin value was 0.8 milligram per deciliter. Mean direct bilirubin value was 0.26 milligram per deciliter, and mean hemoglobin value was approximately 15 gram per deciliter. Of these 481 donor hepatectomies, 226 were left hepatectomy, 151 were right hepatectomy, and 104 were left lateral hepatectomy. Before donor hepatectomy, the mean total liver volume of the donors measured by computed tomography was 1,555 centimeters. In the measurement performed before hepatectomy, we found that the total liver weight was 1.97% of the donor weights. In the control CT performed, it was seen that the current total liver volume reached 97% of the volume before hepatectomy. In the postoperative early period, there were 52 donors who developed minor, moderate, and severe complications. Surgery was not required for any of the minor and moderate complications. In the severe complications, in one patient who developed liver necrosis, liver transplant was performed from the deceased donor within 48 hours after diagnosis. The patients died on day 15 after transplant as a result of pulmonary complications. In the other patient, thrombosis developed in the portal vein postoperatively. Despite all surgical and interventional interventions, the patient died on the third postoperative day. Comorbidities such as asthma, chronic obstructive pulmonary disease, diabetes mellitus, hypertension, coronary artery disease, hypo and hyperthyroidism, dementia, and the panic attack developed in 30 donors, while 175 donors did not have any surgery during the follow-up period. Only 3 of them had incisional hernia repair surgery in the later period. 32 of the donors were operated for reasons unrelated to the donor hepatectomy, such as general surgery, orthopedic surgery, gynecological surgery, urological surgery, plastic surgery, neurosurgery, and the cardiothoracic surgery. As a conclusion, our results show that living donor hepatectomy is a life-saving operation, especially for acute liver failure. But approximately 15% minor and major complications can occur, and additionally, death unwell. Therefore, disease organ donation should be first choice. Thank you for your attention.
Thank you, Dr. Emre. Let's move to the next talk. May I invite Dr. Maria Paula Gomez for the talk on IDTI, second opinion platform related to organ donation and transplantation between healthcare professionals. Dr. Maria.
So, hello, good afternoon, and thank you for the invitation to be here. I will share my screen. So now I would like to talk about IDTI, which is a second opinion platform between healthcare professionals related to organ donation and transplantation. So as we know, there is a challenge worldwide about disease organ donation activity. You can see here, this is from ISOT. In the left side, we can see the countries with the highest rate of disease organ donation, but then in the right side, we also can see all the countries who are challenging to achieve self-sufficiency in disease organ donation. According to the Global Observatory as well, and this is from 2017, so we can see in dark color, in dark blue, the countries with the highest activity in disease, in actual donor from deceased persons, and in light blue, we can see how many countries around the world, they are dealing with how to improve their disease organ donation and transplant activity. So under COVID pandemic scenario, the transplant patients and those with end-stage organ failure are in particular vulnerable position, as we know, all elective surgeries, and it include living donor transplant, were canceled or were delayed during the pandemic. And in those countries where transplantation activity has continued, there were a lot of restrictions or defined stricter donor and recipient criteria to reduce the risk of COVID transmission or an infection after transplantation. DTI, Donation and Transplantation Institute, we are a foundation to advise and support international public and private entities to raise organ donation in the world, improve people's quality of life, and to support programs, services, and research projects in organ and tissue donation. So our challenge at the time was that we received this organized consultation from our worldwide partners and collaborators. Sometimes, so the majority of the time, we're using channels like WhatsApp or email or other non-confidential communication apps, and we were exchanging medical files or medical information. Of course, there were a resource shortage and mobility restriction because of COVID-19 pandemic situation. So our objective was to develop a 24/7 online consultancy platform between healthcare professionals, that it doesn't matter what happened at the time in the world, it was a pandemic situation, or as we all of us experienced 2 days, or yesterday, 2 days ago, that WhatsApp collapsed worldwide, and we were without WhatsApp 6 hours. So it doesn't matter what of all of these situations happen, we already create an online consultancy platform and develop new contents and technological solutions to update the platform. So I invite all of you to visit the website and to log in and sign up. This is a free access for everyone. As I mentioned to you, it's 24/7, is with data protection, use artificial intelligence. You will have access to international experts worldwide. It's about knowledge transfer and networking. Actually, if you scan this code or this screen, you will be able to immediately access to the platform. So this online platform advise about organ transplantation, follow-up in organ recipients, organ donation, living and disease, tissue donation, and of course the trending topic, which is COVID-19 management for donors and for recipients. As I mentioned to you, this is just part of our worldwide network of experts from everywhere. It's not only from Spain. We have from America, we have from other countries in Europe as well. And this is just an example of how our network asks questions to this platform. No, this is particularly from COVID-19 case, and then how this question is answered by our one of our experts. We did a test or a pilot project with this. From April to December 2020, more than 60 healthcare professionals were involved, particularly from Kerala in India, Philippines, Trinidad and Tobago. And the key points tested was the accessibility of the tool, the content, and the communication service. Of course, we would like to acknowledge KMS, the Institute of Medical Science in Kerala. Also, we would like to thank Southern Philippine Medical Center in Davao and Trinidad and Tobago National Transplant Office, NOTU. The results of this pilot was, the majority of them were with a very high score, no? The accessibility, the communication time, the consultant opinion applicability, and the value of the tool, as well as the content of the platform. So far, more than 657 users had this access to the platform, and around we have 51 consultancies on the time. So as a conclusion, IDTI proved a great value for international knowledge sharing and cooperation. It's an efficient tool to support healthcare professionals in the field of organ donation and transplantation. Consequently, more patients can access or will have access for transplantation, and specialization and data compilation open a way to introduce technical and artificial intelligence solutions to IDTI. So my invitation to all of you, as I mentioned, is free access, no cost. You can, and you will have 24/7 contact with a worldwide network of experts in donation and transplantation. So thank you very much.
Thank you, Dr. Maria. The talk is now open for discussion.
Thank you, Dr. Maria. That was an excellent talk. We are moving into a digital world, so this is a good platform to keep ourselves connected across the world. Thank you so much. We'll move on to the next talk.
Thank you. Thank you very much.
Dr. Maria, let's have your second free paper talk in this session on in-hospital transplant procurement managers, the way forward to increase deceased donor transplantation in India. Over to you, Dr. Maria.
So thank you very much. I will share again my screen, and then we will go to a completely different topic or subject, which is how we implement an in-hospital transplant procurement managers in a region in India and the impact of this implementation. The title of the presentation is In-Hospital Transplant Procurement Managers, the way forward to increase deceased donor transplantation in India. So as all of us, we know, in India, live donor transplantation is more common than deceased donor transplantation, although there is a Transplantation of Human Organ and Tissue Act since 1994. So that legalized organ donation after brain stem death. The government of Kerala, in association with Donation and Transplantation Institute of Spain, implemented transplant procurement management model in Kerala with the collaboration of Kerala Network for Organ Sharing. In-hospital donor coordinator have been defined as one of the leading practices for disease organ donation worldwide. The transplant procurement manager is a healthcare specialist dedicated to disease organ donation. So the methodology used, it was an educational and international collaboration approach based on the implementation of a specialized program for healthcare professionals according to our institute. So we start to train them in 2019. We select doctors, intensive care doctors, anesthesiologists, or doctors from emergency department, from the public hospital, but also some of them from the private centers in Kerala. And then the way they were trained was about on-site training. So this picture is about the TPM course that we perform in Kerala. And here you can see some of our professionals, Dr. Nuria Masno and Dr. Ignacio Martinez, intensive care doctors who came to deliver the training. Also, we have international internships, hospital visit, doctors from Kerala visit us in Barcelona and stay in our hospital, and DTI expert visit Kerala hospital to exchange best practice. So these transplant procurement managers became actively involved in the disease organ donation process. And we believe that this is the cornerstone of the success, plus the early and proactive identification of potential donors. So the pathway that was implemented inside of the hospital, starting for donor detection, I just want to highlight the two main changes, which was the active surveillance in the emergency department and in ICU by these TPM, so by the doctors, and also the key role of the TPM in the donor evaluation and in the donor maintenance. So here we can see Dr. Satyadas, one of the ICU specialists from Trivandrum Government Medical College in Barcelona when he came to do his training. And this is some of our visit to Trivandrum Government Medical College with the intensive care doctor of the hospital. So as a result, following the TPM initiation in various hospitals across Kerala, when we compare with 2010 versus 2019, a 60% increase was observed from 30 to 50 organs transplanted in the same period, even against COVID pandemic. No, we in 2020 were under COVID situation, and they were able to increase transplant activity from deceased donor. And the figure that show is from Dr. Murali from KMS Hospital. He's also an intensivist who was trained in Barcelona, and he's one of the TPMs. And he was able, when we compare the conversion rate from 2018 to 2019, he was able to increase this conversion rate to 21%. Now he created the organ donation unit inside of KMS. And as I mentioned before, it was the number from 2019 and 2020 in all Kerala, and this is thanks to Dr. Nobly Gracious, who is a TPM and KENOS director. And then you can see here how the activity increased during this period of time in 2020. So as a conclusion, the collaboration between local and international organizations, the hospital-based organ procurement units headed by transplant procurement manager, and the government support in this activity play a key role for the good outcomes of donation and transplantation programs, even under challenging situation as was 2020 for all of us due to COVID pandemic. So again, I would like to thank the members of my team, Ms. Maria Barros, who is the project technician and collaborating this project, and Dr. Mariano Irazabal, who is an intensive care doctor and also project coordinator at Donation and Transplantation Institute. So thank you very much, and I will be more than happy to answer any question. Thank you.
Thank you, Dr. Maria. The talk is now open for discussion. Any questions?
That was a nice talk, Dr. Maria. In fact, I recollect during 2015-16, when I was doing my DM nephrology, the cadaver transplant in Kerala was going in full swing. And the honors of this transplant, from the identification of the donor to the counseling file, means everything fell on the nephrologist. Then I think with the advent of this transplant procurement managers, things become more useful, as well as the identification as well as counseling will go in a systematic manner, and so that more donations can happen. I think this is going to increase the incidence of cadaver transplantation in our state.
Thank you for your comment, and you are right. You are right. In the past, the model was that the same healthcare professional involved in transplant activities was the one motivated, no, and interested to do this type of role, no, and look for potential deceased donor. But the literature teach us, or we know that the successful models is that there are independent healthcare professionals, in this case, specialists from the critical care unit dedicated to disease organ donation. But you are right, Kerala was doing very well in the past. Unfortunately, for different reasons, they decreased the activity, and now they are again going up with disease donation activity.
Thank you, Dr. Maria. I think we'll move on to the next talk.
Thank you, Dr. Maria. Please note with that, we have concluded the free paper sessions of the first day of ISOT 2021.